Hello, everyone. I'm Allergic Living's Gwen Smith, and I'm here today to co-host with the always informative Dr. David Stukus. Welcome, Dr. Stukus.
Thank you so much. I'm proud to be here, and it's a pleasure to hang out with you and chat about important allergy and asthma information. And of course, I'm here on behalf of the American Academy of Allergy, Asthma, and Immunology, of which I've served as the social media editor. Oh my gosh, I think for the last 6 years or so. So this is gonna be great.
That's great. And of course, I should remind people that they'll know you online as at Allergy Kids Doc. I mean, you almost don't need any introduction at this point. But anyway, so Dr. Dave, it is May, and we
Mhm.
know what that means, both Food Allergy Awareness Week and Asthma Awareness Month. This is a great time for educating, and I know you'll have loads of wisdom to share. So in this video, just to give people a bit of a heads up, we're going to talk everything from latest treatments for food allergy to likely new epinephrine options, asthma inhaler access, both the good and the bad, spring allergies, we're all feeling them, and we'll end with some of Dr. Dave's zingers, his mythbusters. So what do you say, Dave? Shall we dive in?
It sounds great. This will be a lot of fun.
Okay. Okay. I'm looking forward to it. So now this is 2024, and it's a big year of change. In food allergy, we now have two approved treatment options with the FDA approval of omalizumab. Sometimes people know it as Xolair. That was in February. And the big study, in fact, was presented at the Quad AI meeting, which you're representing those folks. And as well, so we've got that option. We've got the Palforzia approved OIT option that's also FDA approved, and as well, an increasing number of allergists are offering oral immunotherapy or OIT with regular food in their practices. So, to get us started, Dr. Dave, what are your thoughts on the expansion of these treatment options?
Yeah, I think for anybody who's watching right now, if you or a loved one have a diagnosis of food allergy and you haven't talked to your allergist in the last, 6 months or so, please make an appointment. Things
Life's
have changed.
changing, huh?
Yeah, it's fantastic. Oh my gosh, it's so exciting that we have realistic, viable treatment options to help essentially anybody with food allergy these days. It's important to recognize that we still don't have a cure, meaning that none of these treatments allow people to either necessarily eat their allergen ad lib, or that they stop treatment and they can just don't have to worry about it. But they are great treatment options to consider.
Right. And are you and other allergists starting to offer the new biologic treatment? And are you finding, is there demand? What are you hearing and seeing?
Yes, I mean, I wrote my first two prescriptions from the American Academy of Allergy, Allergy, and Immunology meeting 3 days
Wow.
after it was approved. I was in my hotel room actually. Yeah, there's different ways to think about who's an optimal candidate. With omalizumab, it's indicated down to the age of 1, and it's really indicated for any food allergy, ideally for people with multiple food allergies. And what it does is it can actually, so this is a biologic that binds the IgE antibody that's involved in immediate allergic reactions or anaphylaxis. And in the clinical trials that were used to get approval for it, they demonstrated that children with peanut and other food allergies who were exquisitely sensitive, meaning they reacted to very small amounts, like 1/3 of one peanut kernel. After several months of treatment with omalizumab, they increased the threshold that they could eat before triggering an allergic reaction. So it essentially gives you that buffer zone, or sort of that bite-proof protection that most people want. So it's a great option. It also treats allergic asthma, environmental allergies. It has other indications. We've used it for more than 20 years. So it has a long safety record and track record of use. And it requires a long conversation with one's personal allergist to see the nuts and bolts of it and what it entails. But yeah, it's exciting.
Oh, that's great. And I have heard some reference to people wondering if a child could have too high an IgE level for that treatment. Is that correct? Or what can you say on that? Because that one comes up a bit.
Yeah, so the biggest hurdle right now is just getting insurance companies to approve it. They lag behind in sort of their algorithms about approval, and that's been the biggest hurdle that I've noticed in our practice is just this lag of waiting 3 to 4 weeks. But we are getting it approved, thankfully, finally. There is a cutoff from the prescribing information of a total IgE level. So we have to measure specific IgEs to foods to diagnose food allergy, but we need the total IgE level to prescribe the proper dose, and the upper limit is 1,850. So for those who have an IgE higher than that, that's where we may have difficulty with insurance actually approving it. As an aside, there's been multiple studies looking at other conditions where people with higher total IgE still respond to therapy. So from a medical standpoint, it still provides benefit. It's just a matter of whether we can get it covered by insurance.
Oh, that's really interesting to know. Okay. Now, if a child or teen could go with OIT or the biologic, if they would be a candidate for either, how do you help them choose?
Oh, that's a nice long shared decision-making conversation. So really, to be honest with you, there's probably three realistic options. So one is, what does it look like just to continue to avoid your allergen? Because a lot of people will choose just no treatment at all, which is great, because they may not feel that they have a lot of restrictions from their allergen, and everybody has their own individual preferences. Oral immunotherapy is more proactive daily management at home. Consistency is the key. We have to make sure that we don't miss doses, that we have a full stomach every time we take our daily dose, that there's no intentional exercise for a couple hours afterwards. And oh, by the way, every dose can potentially trigger an allergic reaction. Now, we try to lower that risk by, a lot of mitigating factors and things like that, but that's something people need to consider. Plus, just what does this look like on a daily basis? And then with omalizumab, this is given by a shot or an injection. It's going to be either every 2 or every 4 weeks. Each treatment dose costs roughly $1,000 to $3,000, but it depends on what insurance coverage is like because, for some cost may be prohibitive or they just may not want to have the injection. So there's some key features to think about and really understanding what each of them looks like is really important.
And are you guys doing a lot of OIT as well at your center?
We are, yeah.
Yeah.
We offer it really for any food. And we've learned a lot about OIT over the last decade, 15 years. And our approach is we try to individualize it towards each child because everybody's a little bit different in regards to their type of allergy, the severity of their allergy, maybe the amount they need to eat to trigger a reaction. The goals of therapy are different for every family. Some just kind of want that bite-proof protection. Others want to go for, a higher maintenance dose, or maybe we can get some of that food in their diet or potentially help them outgrow it. So everybody's a little bit different, but yeah, we've had a lot of success and families seem to really love it.
Okay. Now we get a lot of questions as well about what's called slit therapy or the sublingual under the tongue. That's where you take it's similar to OIT, but you're taking your dose under the tongue. Um, how generally effective is that compared to OIT?
Yeah, that's something we're learning more and more about. There's more limited research in regards to the sublingual immunotherapy compared to oral immunotherapy, but the research that exists demonstrates that it is also effective at promoting what we call desensitization. So neither SLIT nor OIT for most people will allow them to, stop treatment and then eat, their allergen whenever they want. So it's not curing most people. We're seeing that if we started at a younger age, we might have a better chance of achieving that, but that's not a realistic expectation for most people. With slit, we're actually giving a less amount of protein and it's absorbing through the mouth. So you're not absorbing it, you're not swallowing it into the stomach. So there's a lower risk for adverse effects from the treatment, including anaphylaxis, which can occur from oral immunotherapy, but you can achieve a nice level of desensitization over time. You may not be able to raise the threshold amount somebody can tolerate as high as you can with oral immunotherapy, but the trade-off is, you have less risk for side effects. So it's a great option. It's not as widely available as oral immunotherapy because there's some logistics and just how we dose it and administer it and things like that. But it's catching steam, that's for sure. But it's a rapidly changing landscape, which is encouraging. There's epicutaneous immunotherapy that's being developed for peanut allergy, so the patch
Oh,
on the
the
skin.
skin patch, right?
Yeah, yep. Which hopefully will be, FDA approved in the near future. There are folks that are looking at other targets. So omalizumab is just one target for biologics of the IgE antibody, but there's other parts of the, immunologic cascade that can be targeted to try to prevent allergic reactions. So that's under investigation as well. There's pretty cool research looking at the microbiome, which we'll see if that plays out. So yeah, this is, again, it's an evolving landscape. I promise you, if we have the same conversation 2 years from now, it's going to be an even different story by then.
But you know, just to stop and breathe that in for a minute during Awareness Week and month, you know, for years we kept, I don't know how many times I've written that, you know, it would change so much in 5 years, but then it didn't really because there was sort of a go slow. But this really is changing now with two approved products and allergists just generally stepping it up. It really is changed, it hasn't it?
Oh, it has, and I agree with you. I've been saying the same thing myself for over a decade. And not only has it changed, in real life, like these are viable options, but it's continuing to change. And realistically, in 2024, at the time of this conversation, when somebody's diagnosed with a food allergy, they should be having a conversation at that moment about, both prognosis, will this just go away on its own? If so, what's the likelihood? How do we figure that out? But what are the treatment options? That's where we are, and we should be having that conversation with every single individual who has a food allergy.
That's great. And now, food allergy management, there's some evolving approaches in that too. Um, can you tell us what's a threshold food allergy challenge, and when do you recommend that for families?
Yeah, before we had the evidence and the knowledge, it was just we took this widely conservative approach towards food allergy management, meaning that every single person with a food allergy needs to have extreme caution because if they're exposed to even trace amounts, they could have a life-threatening reaction. And we've learned that's not the case. Are there some individuals that are at risk for that from that exposure? Absolutely, but the vast majority aren't. And different people have different thresholds in regards to how much allergen do they need to eat to cause any allergic reaction, let alone a severe allergic reaction. And this is sort of where we are now in regards to management. And this is something that can be achieved through what we call threshold challenges. And it's similar to an oral food challenge where we have somebody in the office setting in a very safe setting, except for threshold challenges, we start with very small amounts of the protein. So for instance, if we do this for peanut, one peanut kernel has approximately 300 milligrams of protein. The first dose I may give somebody is more like 10 milligrams. So super small doses, where if we're trying to prove that somebody's not allergic, we may even start with one peanut or two peanuts. So you start at a lower dose, and our endpoint is also much lower. So we may decide to stop at a single dose of one peanut. Now, for these people, if they don't experience a reaction, does that prove they're not allergic? No, not at all. They're still likely allergic and they can't eat it. But what it demonstrates to them is it's that peace of mind of their natural, threshold set point is higher than they, reach through trace amounts or cross contact or something like that. So it's a very empowering experience. It's really important when people are considering treatment options as well. That's something we do at our center. A lot of families come in saying, we need OIT, otherwise it's not safe for our child to go out in the world. We have a nice conversation. We do the threshold challenge, and they watch them eat a couple of peanuts, and no reaction occurs. Now, they're still allergic and they still have to avoid it, but it just gives them that peace of mind. It's a different way of managing risk and understanding and informing medical decision making.
I mean, I guess we still would have the issues like if you are one of those people who responds to a cofactor, like something like an exercise or, you know, a young woman with, you know, hormones and menstruation or something could be a cofactor, or a teenager with, you know, a young adult maybe with something like alcohol. So I guess you can't know exactly the threshold, but I think what you're talking about, are you not, that when it's that person, especially who's very anxious about their food allergy, that it might just give them that little sense of you've got more of a buffer zone than you know. Is that kind of what we're talking about here?
That's one of the most powerful parts of
Yeah.
that, absolutely, because there's a lot of folks out there that just they take extreme, caution, and they're avoiding very low risk exposures at baseline, regardless of their threshold. And they don't have to, because a lot of these things will pose minimal risk for them. So if we can demonstrate that to them. And as you mentioned, now it gets really complicated because there's cofactors that can change the severity of reaction. It's interesting though. Thresholds remain relatively stable, but the severity of reaction may change based upon. So let's say somebody
Okay.
can, they eat one peanut and they get some mild hives. That's
Right.
probably the threshold. But let's say they eat a peanut while they're doing jumping jacks or they're exercising outside. That's the same threshold to trigger a reaction, but then instead of mild hives, they might start to have vomiting as well. So that's an example of how those, cofactors can change the severity of the reaction. It gets
But
really
it's still
complicated.
all new information, isn't it? When all you've been given before is just, hey, You know, you're allergic, so you have to assume it's severe, and this gives you a sense of where do you fit in the spectrum of that, you know, how highly allergic you are.
No,
It's
absolutely.
so for Food Allergy Awareness Week, I mean, we have to talk epinephrine. I mean, you just have to. If you or your child hesitate to use an auto-injector because it's a needle,
Mhm.
how do you help people get past that?
I tell them that it's going to make you feel better very fast.
It
And
really does from
it does.
experience, I can tell you. Let me
Yeah, right. Yeah,
attest.
we've sort of talked about this. You tell the folks better than I can. But right, so if you're having a true, allergic reaction or systemic allergic reaction, you're going to feel pretty lousy. And the epinephrine, the needle, it's if anything, it's a pinch that lasts a couple of seconds, and it's not nearly as scary as most people think it is. But the benefit of it, my goodness, all the other stuff, like who wants to feel nauseated for 90 minutes? Or longer. We can make that go away, a lot faster. Same thing with the itching and the hives and just not feeling well. You just have that overwhelming sense of just dread and doom, right? So yeah, as much as we can, let's try to remove that fear of the needle.
Well, and once you have the medicine, it is making you feel so much better that you're not so anxious either. At least, I mean, I'm
Mhm.
sure it's very individual, but in my experience, what I remember of it. So, you know, I would definitely encourage people on that. I'd also counsel that if you know, if you haven't done it in a while, do that thing where you pull out an expired one
Mhm.
and you know, do it on an orange or you know, spoil a grapefruit, but you know, just practice a little bit so you won't feel fearful of it. And speaking of needles or not, should also mention that we're in 2024, we're also seeing a lot of progress on these, you know, needle-free epinephrine. And we just wrote recently at Allergic Living on the options that are available, and there's two main epinephrine nasal sprays that are moving both different formulations, but moving along. The ARS Pharma product, that's going back, that's gone back to the FDA in their approval quest, and we should hear about that. FDA has until October, so that's pretty soon. There's also another one from Brin Pharma, and there's also a dry nasal powder that's being looked at that was presented at the Quad AI meeting. And of course, they're doing quite well with that epinephrine film that dissolves under your tongue. But what do you, as an allergist, think about these needle-free options, and what are families saying to you about these things?
It's fantastic. It's always great to have options, right? And this really addresses a lot of the factors involved with non-adherence to epinephrine. It's been well established that, 50% of people who experience anaphylaxis never receive epinephrine, even when they go, they call EMS or show up in the emergency room. They're just not using epinephrine auto-injectors. There's a lot of fear of the needle, unnecessary fear about side effects when administered that way, and all kinds of nonsense that we haven't been able to move past. But this is even better to have these options available. So if we have nasal sprays or if we have a film you can put underneath the tongue and let it dissolve in a matter of seconds or minutes, it's going to really help people use epinephrine a lot faster. It's going to make them feel better a lot sooner. And it's just fantastic to have options.
Now, Dr. Dave, it's spring and everyone's allergies are going crazy. There's so much pollen in the air, and the link to climate change is strong. What have you noticed on just the level of spring allergies you're seeing?
I've probably said this to you before. I used to joke, I mean, we're talking a decade ago, of how the running gag has always been, oh, this is the worst pollen season ever, which we'd always say every spring. It's actually true.
Now
It's
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 true, right?
It is, yeah. It has been for a long time.
Yeah.
So, pollen seasons are starting earlier and they're lasting longer, and we're seeing higher levels of pollen in the air. It's been well documented across the globe. We're also seeing new species presented to areas where they previously didn't grow. So, we're seeing ragweed in portions of Europe where it doesn't belong and things like that. So, yeah, this is the impact that it's having on people with seasonal allergic rhinitis and asthma.
Yeah, I don't think you can see this is I back when we had the print mag, we did Planet Allergy, and That's an old magazine. That was our first kind of kick at the can, but we've been covering this for years, and I'd point out that we do have, if somebody wants to read up more on this, our latest climate change and pollen allergies article, which I'll put in our links at the bottom, but that was based on the study that you no doubt read as well, that had almost 30 years of data, and it was done at 60 sites across North America. And they found, longer pollen season by at least 3 weeks, warmer temperatures, pollen seasons lasting longer, overlapping, how this spurs, carbon dioxide and, tree and plant growth so that they have more pollen. But, if this is our new reality, especially with those overlapping, so say I've got like tree pollen allergy and grass allergy, which is not uncommon. What do you do for folks like that who come in with the weeping eyes and the, sneezing and congestion and just general misery and can't sleep and you name it? So what do you do
Yeah,
for them?
it can really negatively impact your quality of
Yeah.
life. And like you said, it's poor sleep, it's missed work, it's missed school. People are miserable. They can't learn, they can't pay attention. They're exhausted. They're walking around like zombies, itchy zombies. So a couple of things. One is we want to clarify the diagnosis. So there is overlap in the symptoms that can occur. Sometimes, especially in younger children, their symptoms are actually due to viral infections or weather changes, which are very common in this time of the year as well. So is it allergy or not? Because if it is caused by allergy, the treatment differs. We have medications that can try to control symptoms, especially with nasal steroid sprays. We have intranasal antihistamine sprays. We have eye drops of different kinds, oral antihistamines. And then we do have long-term solutions. So we talked about oral immunotherapy desensitizing for food. We've used, allergen immunotherapy for over 100 years to desensitize against inhalant allergies. So allergy shots. There's also sublingual immunotherapy for certain allergens as well. There's even newer approaches in some centers, such as intralymphatic immunotherapy, that's been used in Europe for a long period of time. So we have immunotherapy options for those people that are truly suffering. And then, the biologics, we've already talked about that for food allergy. We've been using biologics for asthma for, oh geez, what, 20 years now? And there's so many
Mhm.
options available. So if we can profile the right patient and target not only, those inflammatory mediators causing asthma, but that are also involved in allergic responses as well, we can really provide a lot of relief for folks. So there's no need to suffer. There are many options available.
I would say, just to add about the biologics, I hear from so many people where that's really made a difference. The ones who have the moderate to severe asthma, where it just has been life-changing for them. So it's no small deal. It can mean a lot. Now, another piece of this climate change puzzle, though, is we're seeing a lot of the wildfire smoke affecting people with asthma, and that was a really big deal in a lot of places last summer. There's some suggestion that we might be looking at similar this summer. If that's a trigger for you, what can you do about that?
Well, that can be a lot harder to deal with because
Yeah.
I live in an area in central Ohio. We didn't have wildfires within 500 miles of us, but yet the smoke still sort of drifted in our area, and it was impacting people with asthma. So it's really something we all have to prepare for. A couple of thoughts. So one is, maintaining good asthma control at all times is important. So if you're not doing well with increased cough or wheeze, or you're needing your rescue medications or having exacerbations, please talk to your doctor. We have so many effective ways to get you under control, and it doesn't need to be that way. So just maintaining good control baseline, and making sure you take your medications as recommended, and things like that. That's important. But then if things do start to flare up, call your physician or your allergist, because we can offer short-term relief as well. And this is where we all need to become, good sort of meteorologists and climate experts, because then we can kind of predict, oh boy, if it looks like, the wildfire smoke is going to be an issue for 3 weeks, there's a different way to manage that as opposed to if it's going to be for 2 days.
Um, Staying with asthma for a moment, there's also the issue of accessing the
Mhm.
right inhaler and the availability. It's been a bit of a roller coaster, a lot of good news this year, but this has been a bit of a roller coaster. A key GSK controller brand went generic, but I'm hearing from all the physicians that not all the insurers are covering the generic. So that's a big issue. Then it may affect fewer people, but the drug maker Teva took some of its digital inhalers off the market. And then there was good news. Political pressure led to three big drug makers agreeing to cap their inhaler prices at $35 a month. And I got to say, I've already heard from people who are paying as much as like $400 a month that they're affected. So that's a huge difference for them. But just this whole thing of, it is very hard on people though with asthma if suddenly you can't, or your insurer's not covering the one that you need, or you've changed and you've got to find the right one. As an allergist at a big center, what's your experience been on these issues?
It's terrible. These aren't new. We've been dealing with this for years, where insurance companies change their formulary with no notice, and patients who've been taking the same medication for years with good asthma control are forced to change to an alternative. And sometimes it's really important because the devices are different. So if we have a child who's used to taking their metered dose inhaler with a spacer, and then they're forced to use a dry powder inhaler, they may not be able to do that properly.
You can't always physically manage it, right?
Yeah, it's just a totally different technique. I honestly, when it's for me, it's more the norm to have insurance companies reject what I think is the best option for that patient in front of me, and they give me a list of alternatives. And this is a real problem because now we have, single inhaler for both maintenance and reliever therapy, smart therapy, which is, GINA guideline based and the United States guideline based. Like, this is great. Like, here's your combination inhaler. It has a low dose inhaled corticosteroid with a long lasting beta agonist called formoterol. And it's basically, you can use this on demand for some people just whenever you get sick. It's a great way to treat intermittent asthma.
Hmm.
Or for those who take it scheduled, you can increase it when you're sick, and it can, keep you off prednisone or keep you out of the emergency room. But a lot of insurance companies don't cover those two inhalers that contain formoterol, and that therapy only works with formoterol.
Right.
So that's a
And that's
real problem.
because it's quick acting as well, correct?
That's
Yeah.
exactly right.
Yeah.
Yep.
Okay.
Yep.
Boy, so that's got to be frustrating. When you're in that position, what do you just try to find the best fit you can, or how do you deal with it?
A lot of prior authorizations. We fight the best we can for our patients. We have a great team at my institution. But for community-based practices or smaller practices that don't have those resources, this is what sucks up all of our time.
Yeah.
And we always want to do what's best for our patients. Sometimes there are equivalent alternatives, and I'll be honest with people too. I'll say, we have three options here, whichever one is least expensive. Let's just go with that. And sometimes we can do that, but that's not always the case.
Yeah, depends on the asthma is pretty personalized. Yeah.
Mhm.
But I mean, I guess as I was saying, the brighter piece is the $35 cap that came thanks to the lobbying of nonprofits like AFA and the Asthma and Allergy Network. So those folks lobbying and getting political action sounds like we still need more. But it's at least a start getting that price cap in. We want to talk some myth busters. These
Mm.
are, I'm thinking some of the commonly heard statements, and I want to know, what does Dr. Dave say? So I'm going to read the statement, and you can tell me, give a brief answer to what's right or wrong. So my child is too young to test for food allergies.
Complete nonsense. I don't know where this started from. So if
You
you're
hear it
if
all the
you're
time, though, don't you?
yes, if you're old enough to develop IgE mediated food allergies, meaning every time you eat the food you have hives or swelling or vomiting or anaphylaxis, you are absolutely old enough to have IgE testing that confirms your allergy. Oftentimes these IgE tests are negative in young children, not because they're bad tests or they're not a certain age, just because they're being referred for non-IgE food allergies. So if you have somebody with, an intolerance to something where they can't digest it very well, their allergy test should be negative. Doesn't mean it's a bad test. It just means it's the wrong test to do.
Hmm. Okay. Um, it's bad to use steroid medications too often for asthma or eczema.
I'm going to say that's incorrect with a caveat. So I think we need to be thoughtful about the dose that we prescribe. So if you have poorly controlled asthma or eczema, more often than not, they're going to respond really well to a good regimen of topical corticosteroids, whether it's delivered to the lungs or on the skin. Now, for asthma, there's rarely the case that we have to use very high doses of these inhaled steroids, and it's very outdated. We have such better options available, as I mentioned with the smart therapy and the combination therapy, but those have lower doses. So they are very safe, and it's much preferred to the alternative of systemic steroids like prednisone, or things like that, which have, tons of side effects. But yeah, we do need to
It's
be very
awful
thoughtful.
stuff to take
Yeah.
if you can avoid it. Yeah.
Oh, absolutely. And then with eczema, oh my gosh, we have so many non-steroid options. So if you do have
Yeah.
steroid phobia or you're not responding well, that's another space that has just truly exploded with great treatment options available, to better
Probably
control
more
it.
than any other allergy related area, correct?
Oh, yes, especially in
Yeah,
the
they've
last
got
12 to 18
tons.
months.
Yeah.
Yeah.
Yeah. If my child has hives, this is another statement. I'm not saying it. This is just what gets said. If my child has hives, I can't give her an antihistamine because it might mask anaphylaxis.
That is incorrect. Antihistamines don't treat anaphylaxis, so why would they mask anaphylaxis? Yeah, I don't know where this came from either, but it's really fear-based, which, boy, I am so opposed to. Just let's move on from the fear-based messaging surrounding all this stuff. There's no need for it. We know better now, and we have good evidence. But no, you're not going to mask anaphylaxis. So it's always, what's the diagnosis? If it's hives, treat with antihistamines. If it's more than hives, then that's anaphylaxis, and that's when we use epinephrine.
I mean, it's fair to say, if you think your child ate something and maybe you're a little suspicious about that, it doesn't seem like a bad idea to keep an eye on it. But
Oh yeah,
I just can't imagine having had anaphylaxis, how that could mask, like they're just not strong enough. Uh,
correct. I agree.
yeah. So anyway, I've never understood that one, but
Myth busted.
you hear it a lot. So this one I hear time and again. Food allergy reactions get more severe every time you accidentally eat the allergen.
Yeah, that's actually not true. So we sort of talked about this where we know for most people, and they've done these studies where, you give them the same dose or, so they're pretty consistent in regards to how much do you need to eat to cause a reaction and what types of symptoms that you have. But here's what comes into play is what we talked about with those cofactors. So when we have more severe reactions, on subsequent ingestion, oftentimes you either ate more of the allergen, so you ingested a higher volume, higher protein content, you had more IgE activation, things like that, or there were other cofactors involved, whether it was exercise, you were sick with a viral illness, or you had a fever, women who are on their menstrual cycle, if you're taking medications like, ibuprofen, or Motrin. These are some of the factors that can really worsen the severity of it. It's interesting that nobody ever talks about how food allergy reactions may be less severe the next time you react, which is absolutely the case as well, for similar reasons. Because maybe the first time you had the cofactors involved, you ate a higher amount, or over time, especially for children with milk and egg allergy who tend to outgrow this, by school age, their reactions just get less severe, over
Hmm.
time when they're outgrowing it.
So don't go by that. Try not to eat your allergen if you know you're allergic. Keep that keep the management going. But okay,
Yeah,
so
don't confuse me for saying go ahead and eat it because it'll be okay.
no,
That's not
I
what I'm
didn't think
saying.
you
I'm
were.
just saying don't be afraid.
Yeah, exactly. Okay, last myth buster for you. For my dog allergy, I'll be fine if we get a hypoallergenic breed.
If you can find one, that's great. So this is a marketing tool. This is not science, or anything. So the dander that causes allergic symptoms comes from saliva, from the sweat glands in the skin, and from the urine. There are certain breeds that have less amounts of some types of dander, but there's, several different types of dander that can trigger allergic reactions. So there's no true dog that is truly hypoallergenic. What is hypoallergenic for one maybe you may cause severe allergies for somebody else. Unfortunately, we can't really test for every breed of dog, but a lot of people with dog allergy can find certain breeds that don't cause them to be miserable. And I often recommend if you want to bring a dog into your home and you have dog allergy, go spend time with that specific breed or dog. Love on it, rub your face on it. If you break out in a rash and start sneezing your head off, maybe not the right dog for you. If nothing happens, that's a clue that maybe you might be okay with that. And then, of course, we always have ways to control symptoms if they occur down the road. But yeah, unfortunately, don't spend the extra money on what's called a hypoallergenic dog because they don't exist.
Just as we wrap up for both Food Allergy Awareness Week and the Asthma Awareness Month, Dr. Dave, these are pretty hopeful times. We obviously some challenges, but we're seeing, particularly in food allergy treatments, a lot of evolution. I hope we'll see more. What are your takeaways for us for Awareness Month and Week?
Yeah, two big takeaways. One is we have options available. Don't settle for less. We truly live in an age of individualized treatment for both food allergy, asthma, allergic rhinitis, eczema. I promise you, there are options out there that can find you, the path that you're looking for. So have those conversations, and these are exciting times. Takeaway number two, given the time of year, I always like to recommend folks that summer is a time of fun and chaos. Our schedules get turned upside down. There's vacations, the kids are out of school. It's a great time when people often will lapse and using their medications consistently or having access to epinephrine and things like that. So as much as you can, put some reminder systems in place. And please, if you have a child who's going to school next autumn and they require forms to be filled out by their allergist, don't wait until the day before school. Please, I beg of you, send them in early. We love getting them in June.
Never too soon to start and no lapsing. Okay.
Yeah.
That's great. Dr. Dave, thank you so much for co-hosting on behalf of Quad AI today. I really appreciate all the work you do to educate. You do so much for us all, especially with all these online moments to spread your work beyond Ohio. So it's great to see and much appreciated.
Well, thank you very much for all that you do as well. And it's always fun to chat with you and collaborate. So thank you.